I don't hear anybody.
Mark, your microphone is not activated.
Okay, so good morning, good afternoon, good evening. Welcome to the opening ceremony weekend of the Academy of Applied Myofunctional Sciences 5th Congress, virtual reimagined. So technically we launched on August 1st, but this is our opening weekend ceremony. We're going to have 9 opening panel discussions, 5 today, each at the top of each hour, starting at 9 a.m. Pacific, 1800 hours Paris. And today being the 29th of August, we will carry into the 30th of August today when we have some of our representatives from Asia and Australia. But we tomorrow we'll finish with the last 4 of our 9 tracks. We'll have opening statements. All of the 100+ speakers have been challenged to answer 2 questions. What is the problem related to their track from where they sit and where they work? And what are key priorities to have a solution? And in some cases, what may feed into a white paper. We have 3 white papers that will be coming at least that are already in development for our scientific meeting, this 5th Congress. And then finishing tomorrow at 1 p.m. Pacific time or 2200 hours Central European time, Paris time, we will have our opening ceremony where we will be so excited to announce to you the formation of 4 new nonprofit scientific societies or public health entities. So it'll be a great surprise. It'll touch people around the world. We have wonderful announcements, maybe some great surprises as well. And we will be carrying on with live programming through October 1st of 2020. We will have our closing ceremony at 9 a.m. Pacific time, 1800 hours Paris time, some closing panels on September the 27th. So this virtual Congress reimagined involves so many moving pieces. We invite you all to join us at aamsinfo.org. We are live streaming around the world via YouTube and Facebook, and our 5 forums or fora that have just been released gently have already seen in the last week over 100,000 individual views, and just by some metrics. We haven't been able to count them all. We've had over 1 million page views by one metric. There are several other metrics for us to look into. And we're somewhere around 1,000 Congress registrants, and we're hoping to bring in many more. For those of you who are Congress registrants, we will have access to all of our 136+ presentations through October 1st. And for those who want to join the Scientific Society, the AAMS, we will go until December 31st. But let's get right into it. This track, pediatric orthodontic intervention at the earliest age possible, a call for an international pediatric orthodontic society. I'll let the cat out of the bag. One of the 4 new scientific societies beyond the 23 we've helped launch around the world in the last 9 years is going to be an International Pediatric Orthodontic Society, EPOS. We have our 2 co-presidents chairing this session. I'll introduce them both. Dr. Kevin Boyd is a colleague and dear friend. He's a pediatric dentist from Chicago. You can see his biography on our webpage. Dr. Patrice Bergeron is also a dear friend. He is an orthodontist based in Geneva, Switzerland. So I know Kevin Boyd, you have some pressing surgical attention and some patients waiting. So please jump in and go first. But just one more thing. All of the 100+ speakers who will be part of these fora or panel discussions today and tomorrow have been tasked with answering 2 questions. What is the problem related to their track or their symposium? And what are solutions or what may go into a white paper? Thank you very much, Dr. Boyd.
Thank you, Mark. First of all, I'd like to acknowledge Patrick Fellis, who started the French Society of Pediatric Orthodontics. We would not even be talking about this today had Patrick not initiated, made people aware that we need to align with like-minded people who I'm sorry, is somebody trying to talk? Okay. Anyway, I heard a little noise. So anyway, thank you, Patrick. And I am honored to be co-president, the inaugural co-president for the International Pediatric Orthodontic Society with Patrice. I see, first of all, one of the biggest problems that's facing us today is just the public perception. Why would you want to treat orthodontics early? And just the way conventional orthodontic approach is, see them by age 7 and start treating them by 10 or 11 and minimize the burden, financial burden and burden to the child. Well, this is something that I think we can easily overcome once some basic facts are understood. And one is that when malocclusion first appears, and it could be even in utero that we can pick up retrognathia, but let's leave that aside. In the first 2 or 3 years, 1,000 days alive, we can pick up maxillary transverse deficiency. We can pick up sagittal problems. We can pick up vertical problems, high narrow palates, lip ties, tongue ties. These are all malocclusion phenotypes that will not get better. They cannot self-correct. There's evidence that supports that goes back 100 years. Okay, so they persist and they worsen, and they often are or become comorbidities with sleep-related breathing disorders and associated neurocognitive and neurobehavioral problems, and other systemic illnesses. So just as we would not let a child who was born with congenital cataracts, and again, when this was first appearing, the mindset was, let's let the eyeballs, let's let them mature before we do any sort of intervention. And those children went blind. Okay, so we learned the hard way. Sometimes it's, not as maybe as serious as going blind, but possible other systemic problems related to early childhood malocclusion can lead to all poor quality of life for the whole family, obviously the affected child and their siblings, and also so many deficits that possibly by just getting the malocclusion off the table, not promising that you are going to get the kid into Harvard. We don't do that. We just do dentistry. But overcoming these barriers, first professionally, that this is something that is very important to do. It's medically defensible to at least assess risk and then either refer to somebody who knows how to treat in the primary dentition, that has the skills and experience with behavior guidance, behavior management, child development, like a pediatric dentist does. Recognize that orthodontists and general dentists may have these innate skills, but they're not taught to them in their residencies. Orthodontists in America do not get any training in behavior guidance. So they are not at fault for not being comfortable treating kids at a young age. So just cutting it brief here, these are things that I want to do. I want to erase the misperception that we should not be dealing with malocclusion in the primary dentition or early mixed dentition. We should. And we help the public demand it. Right now, the demand is starting to increase. That's why I have to leave this. I mean, we are getting so busy as we are recognized that we will not only assess risk, but we will treat kids when they're 2.5 years old, like they did 100 years ago. And we have to get more people that are comfortable doing this. And I think that's going to be a major goal of the International Pediatric Orthodontic Society, is to change public and professional perception of when orthodontics, malocclusion should first be recognized and when it should first be treated. So that's all I have to say.
Thank you very much, Kevin. I would like to welcome Patrice Bergeron. He has a very large practice in Geneva. I think he's treated maybe more than 5,000 cases in very young age, maybe even 5 years of age. So Patrice, please join us.
Thank you.
Welcome.
Thank you, Mark. Thank you, Kevin. You know, it's a pleasure for me to be the president with you on the IPOS. When we decide, you know, to build the IPOS and to do a meeting with the AAMS all together, is because we will show that the way is to treat the children and to improve the life of the kids for the life and for the future, you know. So 1 year ago, you know, or some months ago, I was the president of the SFOP, who was decided and designed 10 years ago by Patrick Felus. You know, he's like not my mentor, because it's really one guy I love, because he's the only guy who decide, you know, to do his job like an orthodontist only for the children to 3 to 6. So I really, it's really an honor for me to be the president of the French Society, but in the same time to be the president of the IPOS and to decide, you know, to build the IPOS and to do this Congress with the AMS. So Mark, thanks for your efforts. Thanks all of you to be here. Yes, I think there is only one way for orthodontic treatment, and there is only one way if you want to focus about the medical part of the orthodontic treatment. I'm not speaking about the alignment of the teeth. I'm not speaking about the smile. I'm speaking to improve the life. And really with the 9 tracks, with the 120 speakers, we all going in the same way. If you want to improve the myofunctional therapy, if you want to improve the airway, if you want to improve the face, the growth, and the future of the children, you want to improve the face when it's possible. You know, it's only possible at the early age. And after, it's only surgery. There is no way. There is no way. And the way it's not really to improve the smile and to move the teeth. The way is to improve the jaw, the growth. It's like you burn, you know, with the genetic of your parents, and at this time you are like a gardener. You need to improve it, and you need only to focus about the functional way and the face, to improve really the growth and the face for the patient. So the orthodontic treatment for me is like we say all the time, you know, if you see something on a patient, you know, and decide to do nothing, it's a crime, you know, because there is no profession in the world who sees something happen and to say, yeah, it's malfunction, and you wait. Why to wait, you know? I think because why we wait? Because it's the question we need to answer after, you know. And why? It's because it's not so easy. It's not the same to treat a child, a kid's like to treat an adult or a teen. It's another way. It needs to be another treatment. It needs to be another chair, another room. It's another mind, you know. But we need to do it because it's the only way for the medical part of the orthodontic treatment in the world. So I'm really happy to be here. I'm really honored to be the president with Kevin Boyd. I'm really honored to have all this panel discussion with you. I want that each of you discuss and explain what you think about this way. But really, for me, there is only one way, and it's like it's a crime to not do this treatment. So I will do my best, you know, to explain to the world how we can change it, how we can improve, and how we can share our knowledge together. Thank you.
It's really a privilege and exciting opportunity to be on this journey with you. The theme for the entire Congress this year is myofunctional orthodontic intervention at the earliest age possible for the most amount of people. And it's really quite the opportunity to be able to envision the formation of a global scientific society and clinical society, educationally oriented as well, that has the possibility to transform lives. So we're really excited about that. That's one of the reasons why we picked the theme this year as we did. And we are headquartering this institution in Geneva, Switzerland. Someone needs to be muted. Thank you. So now it is my sincere pleasure and honor to introduce, sorry, someone is on, maybe it's Tom. So it's my sincere pleasure and honor to introduce a dear friend. Since we met, it's been a wonderful coming together of our families and friends and our ambitions around philanthropy and passion for helping children. Dr. Patrick Fellis, he is, I would say, a visionary. He was knighted by the French government as a chevalier for his work helping children. He founded the first pediatric orthodontic society in the world, the Société Française d'Orthodontie Pédiatrique, which is still the only society to have that focus in the world. He's an orthodontist and I would say a stomatologist and an inventor. He's based in Paris and also a little bit south of Paris in the countryside. So please join us, Dr. Fellis. Patrick, we can't hear you. So here, I'm asking you to unmute. Okay, maybe now. Go ahead and speak. Patrick, we're experiencing some technical difficulties. I'd say let's move forward to one of our founding board members for EPOS. Patrick, can you say something? Can we hear you? We will manage perhaps in the orthodontic track to work in Dr. Fellis if he still has some technical difficulties during this panel. But let's move along because we have a lot of ground to cover. Dr. Justin Lee is on the board of the Asian Pediatric Orthodontic Society. He's a professor at Seoul National University. He is very passionate believer in early intervention. He's even established training facilities in rather large pediatric centers in India, where he travels from his, I would say, giant practice in 2 5-story buildings in Gangnam in Seoul, Korea, to India several times a year, where he's established a training center out of his passion for helping little kids. So thank you very much for your work and for joining the EPOS board.
Yeah, thank you very much for your kind introduction. It's my pleasure and honor to participate in this wonderful group. So, as the past 30 years as a pediatric dentist, I really have recognized the early intervention of all problems, not only the dental caries. The malocclusion can be prevented or early intervened. So it must be as early as possible. So I think this group and this society is really, really important for the future generation. But as you know, I'm not a researcher, but I'm just a clinician, but I try to my best to contribute to this society. Thank you for having me.
Thank you very much, Justin. I would now like to welcome Karine Ben Yunis. She's an orthodontist based in Paris. Unmute yourself. And I've just asked you to unmute yourself. There we go.
Okay, it's okay.
Okay, good morning.
Heard me? Good evening here.
I can hear you.
Okay. So I am an orthodontics. I am in Paris. I was a student with Dr. Fellis in the hospital in Paris. And I think many years ago, 30 years ago now, and I think we have no choice with early treatment. Early treatment are really mandatory when there is a risk of complication or risk of aggravation. So when you have a risk about trauma, you cannot let the teeth have trauma. So it's an obligation to make early treatment in this case. And also when we have a risk of aggravation, we cannot say, wait, it will be surgery. It's terrible surgery. And it's easy to treat early. And when you treat early, sometimes you understand how to treat later. So it's a chance, and we don't have to let the chance go without keeping the chance when you have the chance. So to treat children, it's take the chance that we have. I'm not sure. I hope you understand me. Sorry for the bad English. Okay, thank you.
C'est merveilleux.
So,
Merci beaucoup.
voilà. We have no choice. We have to do it, and everybody has to do it, but it's important to do it correctly.
Fantastic.
More important because when you have young children, all what you do will be bigger. So good treatment will be wonderful and mistake will be bigger than with an adult. But don't do not do treatment when you have to do it. It's a big mistake also. So that's it.
Thank you very much. Merci beaucoup. I want to see if Dr. Fellis is able to join us now. Patrick, are you there?
Just,
No.
I'm not sure. Just try
Okay.
to change to the phone than the computer because there is a problem with the microphone.
Okay. Just Patrice and Kevin, you've been on this adventure with us. Patrick has had this vision for intervention as early as possible, and he focuses his orthodontic intervention around function. I think, I've heard him say many times, he doesn't even use brackets. And
Yes. But the apparatus is a meaning. It's not a therapy. So, what is important, it's not the kind of apparatus you use, it's how you use it. Like we are French, so you have wonderful food, but with the same ingredient, you cannot have the same food. So it's important to know to use the apparatus you have.
okay.
Yes, there is the many ways for success. This never depends on the supplier. The more important is to go in the same way, the same way, to improve the growth of children. We always need to find a way to improve. And when we are doing a diagnostic about anything, and you say, yes, it's not normal, you need to find a way to improve it. And all the people in the world, it depends on the profession. It could be Mark, like executive director, it could be an orthodontist, it could be a myofunctional therapist. All people who can help the growth of a children and who can do a diagnostic and to improve the way and the life of these children is welcome to our society.
I say there are many different strategies that we can use at a child's different readiness to receive treatment, the parents' readiness to receive treatment. But there's only one principle that we cannot violate. We cannot compromise. We can compromise on strategy, but we cannot compromise on principle, and that is to optimize a child's craniofacial respiratory structure and function at the earliest possible age. It's pretty simple, isn't it? I mean, but not necessarily really easy to do until you get comfortable with it.
Yeah, totally agree.
Patrick, Fellis, have you regained your voice? Okay. I would like to bring in right now is Dr. Herman Ramirez, who is driving right now. That's the best he could do to jump into this schedule. We have these schedules around the world. Welcome, Dr. Ramirez. Thank you very much for your contribution to the program.
Hello, Mark. I don't know if you can hear me. I am on my phone.
Yes, we can.
Okay, great. Thank you very much. I am really excited to participate in this wonderful Congress and all your efforts, and also to be part of this great idea of the International Pediatric Orthodontic Society. I think one of the problems is that we dentists were trained just to focus on teeth. we are not trained to evaluate the structural problems and the functional problems. And the other paradigm that we have to change is that the dental community is spreading the word that normally when we do early intervention, we need to do a further treatment later. And that is not true. If we start at early age and we focus on treating all the structural and functional problems, we can have a very successful result with stability along the life. And the other thing that we need to focus on working is communicating to people that the problems that we are seeing in the mouth is just a red flag, and they are going to lead to many chronic problems in the future in that patient. So the earlier that we intervene, the better for the patient. And our goal is not to align teeth, is not to give a beautiful smile. Our goal is to give health to the patient. So thank you again for inviting me, and thank you. I am really willing to participate as a member of the new International Pediatric Orthodontic Society. Thank you.
Thank you very much, Herman. I think when people start to realize the potential here, people get excited, so passionately involved. Even, medical doctors, pediatricians, realizing that, why wait? I mean, something just for point of discussion and clarification, orthodontic intervention in terms of guidance around the world, I think kind of consensus for orthodontic societies is around age 11, and maybe early on is considered age 7. But what we know from our studies and some of our brilliant presentations, like from Dr. Karen Sproit from INSERM in France, or Dr. Shannon Sullivan, is that if we wait to intervene past age 6, these children's brains will be permanently, how do you say without being indelicate, but they'll have a capacity that not optimal. You could say affected. Okay, that's a polite way of putting it. But there's going to be issues where they show up with ADHD on the spectrum, different kinds of disorders, autism. There was a landmark study from Karen Bonnick published in Pediatrics in 2012 with Ron Chervin that looked at 11,000 children in the NHS. It was retrospective data analysis, but these children who were mouth breathers, mild functionally disordered, I mean, they would consistently have 10 points less in IQ, 60% diagnosis with a behavioral condition. Really, regardless of economic background or education of the parents or the families, this is something we can intervene early on at early age. One of the founding board members for EPOS is Dr. Jade Miller, who's a trustee of the American Academy of Pediatric Dentistry. And, this is a leading organization and also a very big ship in this space, pushing for screenings at age 1. But I am so excited about the potential from our white paper on reimagining the first 1,000 days of life, and our second white paper, which will be looking at pediatric orthodontic intervention at the earliest age possible. So we've got presentations with children at 12 months of age from Wilson Arago in Brazil. We've got early interventions from a great number of people, Dr. Lee. Really, there's so much that can be done at an early age.
And I totally agree with that, Mark. And if you see my lecture, I present a case that I started treating at 4 months of age, and when the child was 5 years of age, totally treated and totally corrected. That is something that I have done all my life. Well,
could I throw it out there? We have some of our speakers and some other, perhaps even residents, some guests of some of the chairs of the upcoming symposium panels. I'd like to throw it out there. what would people like to see in white papers? What would they like to see explored? I know later today, track 5 will be exploring frenulum inspection and revision. And track 7 tomorrow, we're going to be talking about sleep apnea. Track 4 today, we're going to be talking about breathing re-education. Track 2, which is coming up at the top of the hour in just about 30 minutes, we're going to be talking about reimagining the first 1,000 days of life, which includes gestation, with myofunctional principles. So can I throw it out there to the panelists assembled here?
Mark, I think, if we are looking about all your tracks, it's like we are looking about all the benefits for the early orthodontic treatment, and if we need to work all together on a white paper, it's important, to go on the health way, not really on the line of the teeth. I think if you have a good health, you have natural beauty of your face, and after we can the position of the teeth, but it's easy, so it's really hard. So now I just want to introduce Patty Kubels, who is our vice president of the French Society. It's the future, because it's more younger altogether, but his family is pediatric, so she lived when he was young about the medical pediatric at home, and I'm happy and honored to have her, the vice president, and I want to know what she's thinking about this early treatment and how she feels this new way, because like the way we have the vision to share it with all the people, and we need to have with the new dentist, with the new orthodontist, to be sure they are in the same way. So, Patty, if we can go to
Sure. To introduce Patty Kubelis Ricard. She is an orthodontist and she's very passionate. She's recently relocated to Barcelona, where her family has a medical practice. She is a I think, like Patrice said, she's vice president of the French Pediatric Orthodontic Society. So it's wonderful to have you here today. So please welcome and join us. And remember the 2 questions we're looking to examine. What do you think the problem is in the relationship to this track? And what do you see as solutions? And what might you want to see in a white paper?
Hello, good evening. Thank you very much for introducing me. It's been a great Congress, very different from all the others we've done before, but it's been great. And actually, pediatric orthodontics, I think that it's the future of orthodontics in general. What I would like to see, I would like to see all health professionals understanding what we are doing as pediatric orthodontics. I can see now that our fellow dentists sometimes do not understand what are we treating at early ages. And I've been asked sometimes by dentists, what are you going to do? Put braces on 3 years old? I can see that they don't understand what is it about. I think that we are teeth-centered and we should be bone-centered. And I think that the way to make people understand what we are doing is, I think that pediatricians is the key to find the way to make people in general, parents, to understand what is necessary. And I think that the important thing is breathing for children and development, bone development, instead of teeth. Teeth will come later. And I do think that general orthodontist or dentist in general, the training that we receive doesn't prepare us to understand pediatric orthodontics needs.
Thank you very much. These are great points, and I've been excited in the few conversations we've had. And I'm excited to see these young, new generation orthodontists, pediatric dentists, sleep specialists coming in. We've got a great new late-breaking paper, a meta-analysis from a team from University of Indiana and Stanford on myofunctional therapy and pediatric sleep apnea. And that will be coming in this week. We have some extraordinary work to do, but some key point that you made, you would like to see all health professionals understand what it is we're talking about. And I hear this complaint so often. Why can't we get the American Academy of Pediatrics? Why can't we get the American Academy of Pediatric Dentistry or other great, regulatory or position policy statement making organizations to weigh in? And I think part of the mission of this society is to create the science necessary for that story, not only to be heard, but to be mandated, because it will be unavoidable. We know amongst ourselves clinically that we have something special here. We get results, but we need to do the kind of studies necessary to really allow for that story not only to be heard, but to be actionable and unavoidable in terms of action. I think. Yeah, thank you very much.
The patients are really very happy with all the work we make. And with pediatric orthodontic, I have a very small office in Paris. In a place there is orthodontics, and people like very the result. And you have big problem, and you can find some resolution very easy. The people are very, very happy about that.
Voilà. Hello.
Now, I would like to welcome Dr. I'd like to welcome Dr. Patrick Fellis. Thank you very much. Patrick, please say a few words.
Okay. It was very difficult for technical problems. So I have two main things, because in France, it's rather particular because we have a recommendation about orthodontics, and it's a rule: you must treat before 6 some pathology, some dysmorphosis. For some dysmorphosis, you can wait, but there is a lot of dysmorphosis you must treat early if you have diagnosis it. The problem is that in France, very few orthodontists take care of this recommendation, and they don't want to treat early. Why they don't want to treat early? The first thing is that they don't know how to treat. And early pediatric treatment, it's not to take braces, to take all the adolescence technique and do it for children. It's not the same. And if we want the pediatric orthodoncy rise in the world, the first thing is that the treatment will be efficient. And the treatment cannot be efficient if people don't know how to treat. And when people treat, we must take care that there is no relapse, because I saw lots of children who have been treated early by other practitioners, and 2 years later, it's the same, there's a great relapse. And so if you just treat the dysmorphosis and you don't treat the dysfunction, it's evident that we have relapse. So we must learn how to treat children, and we must treat how to have a myofunctional rehabilitation. I think the French Pediatric Orthodontic Society and EPOS must organize treatment courses to learn in the world to the patient, because in the university, they don't take care about that. So we must have courses and organize courses in French, in English, in Spanish, and all in other languages. I think it's the main thing. Treatment must be efficient. Treatment must not, there is no relapse, and people also must learn how to treat young children.
I just one second, just really I think if you look Patrick, he's an orthodontist, for 40 years. And now it's an orthodontist who is thinking about biofunctional education, It's an orthodontist to move to neuroscience. And I think neuroscience is the future for the biofunctional and for the orthodontic treatment. But one thing is important, it's why I say Patty and all together, in the education. We need to go in all the country, in all the university we can, to educate the people, to educate the professional and the people about the orthodontic pediatric treatment. But like say Patrick, it's another treatment. It's not the same treatment for a teen, for an adult, and for a kid. It's really another mind, another technical treatment. It's another philosophy, but it's really the future. And I think that with the AAMS, with on track, we can see all the benefits in the future for this treatment. So really, Mark and Samantha, thank you for your effort. Thank you to organize all these rooms, all this meeting, to be sure we are all together, we are the same way, and we will find the way to change the world for the lives of the children. So really, thank again all of you. We need you. We need you to go to the white paper. We need you to be sure we are going in the good way. We are not going in the way to align to this. We are going to the way for the health and to improve the life of a child. And there is nothing who is better than to improve the life of a kid. Nothing.
I think there is one thing which is very important. We must have the help from pediatric dentistry, because pediatric dentists know very much more the patient, young patient, if they know how to treat. So we must learn orthodontic pediatrics to pediatric dentists and to orthodontists, and even to omnipractitioner, because practitioner can also, if they want, they have some orthodontic notion, they can also treat. So we must have courses, formation for pedodontists, for pediatric dentists, for orthodontists, and even for all the practitioners.
So,
Do French dental schools have specialty training in pediatric dentistry? Do French dental schools offer postdoctoral training in pediatric dentistry?
No.
Anywhere else in Europe? Does anybody in Europe offer?
No, they don't do. The pediatric dentist in French, the Société Française de Pédodontie, are very next the orthodontist, then ask the orthodontics to give some information, and orthodontists don't want the pediatric dentist do this part. So there is not really formation for the pediatric dentist, and we must learn our view, how to treat easily with a simple appliance, and not with braces, with mechanical and uncomfortable appliance.
We have a lively discussion.
We could make that a goal of the
Kevin,
International
Patrick,
Society.
we've gone a minute over here,
Okay.
and I am so excited about this discussion, and it's going to carry on. And of course, you're both invited to come back in at the orthodontic intervention and myofunctional panel, which will happen at 11 a.m. Pacific time, or 20 hours European time or Paris time. But right now, we're coming up on the end of this panel. I want to thank everyone. And the first EPOS, or International Pediatric Orthodontic Society, will be held in conjunction with the 6th AAMS Congress and also the World Sleep Society Congress, which will be in Rio de Janeiro. So let me just leave you with that. Rio de Janeiro, probably it's gonna be moved from September of 2021 to March of 2022. So everyone go to aamsinfo.org, stay in touch with us, and all of the speakers for the next track. We're going to log out right now. And if you're joining us for the second panel, please log back in.
And I want to say one thing, please, if I can. I can say it's maybe
sorry,
something
no,
new.
I'm sorry, we've gone over time. Thank you very much.